Hello, my name is John Reynolds. I'm Professor of Surgery at Trinity College, Dublin and St James's Hospital. I'm a member of a multidisciplinary team located between St James's and St Luke's Hospital in Dublin that looks after approximately 200 new patients each year faced with a diagnosis of esophageal cancer. The goal of this presentation is to inform new patients and their families of key elements of the treatment involved in esophageal cancer. This may involve major surgery, and it may also involve the administration of chemotherapy and radiation therapy.
My name is Declan Byrne. I was diagnosed with esophageal cancer in September 2000. And the very first reaction I had was the use of the term cancer. It has such terrible connotations. You know, I felt that this was a death sentence, and it was a very traumatic time for myself and my family, coming to terms with the whole notion that I could have cancer. Once you get over that initial shock, and it absolutely was a massive shock personally and for my family, as I said, you then begin to think, you know, what chances have I got and what form and shape the treatment will take.
We know a lot more about the exact prediction of survival possibility for a patient once all the treatment is completed and the operation's been done and what we remove has been analysed under the microscope by my colleagues in pathology. So we know a lot more at that time, but it's impossible for me on day one like this when we meet to be able to say to a patient, this is the percentage chance that we can cure you. We just can't do that.
My name is Jenny Moore and I'm the upper GI cancer nurse with Professor Reynolds and his team. Our aim for you and your family for the next few months is to get you through this treatment pathway in the least amount of distress as possible. As you will be meeting a lot of new people who are experts in providing your care, I hope to be a constant link throughout that journey.
All patients with a diagnosis of esophageal cancer will undergo staging. Staging will determine whether the disease is localized to the esophagus and maybe the surrounding lymph glands, or whether there has been any further spread. Staging will include, for everybody, a CAT scan and a PET scan, and for many patients another endoscopy which is combined with ultrasound, known as an endoscopic ultrasound. Every patient with suspected or diagnosed esophageal cancer will be discussed at a multidisciplinary team meeting, and a consensus recommendation for their management will come out of this meeting. In our experience, for every 100 patients that we are referred with esophageal cancer, approximately 50 will have disease localized to the esophagus or surrounding glands and will be suitable for a treatment that is designed to obtain a cure if that is achievable. Within that 50% of patients, approximately half will be offered chemotherapy, or more usually chemotherapy combined with radiation therapy before the operation, and the other half will just have the operation alone.
Chemotherapy forms part of the trimodality treatment of resectable esophageal cancer. The chemotherapy is given by an intravenous drip as an inpatient with radiation treatment prior to surgery. The chemotherapy is administered either in St James's or St Luke's hospitals, and the patients, if they're in St James's Hospital, travel daily to St Luke's for the radiotherapy whilst getting the chemotherapy, and if they're in St Luke's they have both treatments given at that site. After completion of the radiotherapy, the patient has a gap, and approximately a week or two later will come back in to St James's Hospital for a second cycle of chemotherapy, which lasts approximately 7 days. When the patients come into hospital for their treatment, they're seen by an oncology nurse who explains all the side effects of therapy to them. And these side effects include things such as nausea and vomiting, risks of infection, and sometimes risks of bleeding. A number of weeks after completing the second cycle of chemotherapy, the patient is reassessed for fitness for surgery.
Patients will generally attend St Luke's for their first visit within 1 to 2 weeks of being seen at St James's Hospital, and most of the important information that we need in terms of scans will have been undertaken at St James's, including CT scan, PET CT scan and the endoscopy, which will have been part of the initial workup of the patient. When they come to St Luke's, there are a relatively small number of procedures that need to be undertaken before they can start treatment. Most specifically, what they require is a process called simulation, and that requires the patient to have a specialised form of X-ray where they will swallow some barium contrast, and also they will require a CT scan, and both of these tests give us the information that we need to map out the location and the technical way in which we will give the treatment. And that process actually requires a couple of days' work, and that's why there is a gap of around 1 week between attending the hospital for simulation and ultimately starting treatment. The treatment itself is relatively simple for most patients. It requires 15 treatments over a 3-week period, being treated Monday to Friday, and per day it takes in the order of about 15 minutes. It's a comfortable treatment process with the patient simply lying on their back on a treatment couch, and they should be aware of nothing else other than some machine movement and perhaps some machine noise, but the patient should really have no other significant inconvenience or symptoms associated with the treatment on a daily basis. Towards the end of the treatment, some patients do experience some mild discomfort on swallowing and also some fatigue, but this clears within a very short time after completion of the radiation course.
On arrival at St Luke's for the radiation, I have to be honest and say that the radiation to me was very, very straightforward. The facility itself is really conducive to peace and, nice atmosphere. The radiation was conducted over a 3-week period. The first week is probably quite difficult in that the first week of my treatment you're doing chemotherapy and radiation, and the chemotherapy lasts 12-hour cycle, and then you finish the cycle, you have a shower, and then you get in a taxi, you come to St Luke's, you have your radiation, and then you go back and you repeat that for 7 days. The following 2 weeks is probably more straightforward. I came actually as an outpatient. I come up and down every day for the following 2 weeks, and the radiation was quite straightforward. I had some feelings of tiredness, but no major side effects, no sickness, and mostly the routine went to plan. Having gone through the combined therapy of radiation and chemotherapy, the wonderful news that I had prior to surgery was that the tumour had reduced in size approximately 60%, and I felt it was really worthwhile, to have gone through all of that, and I felt quite set up, if you will, for surgery.